Hello, my name is Bob Gould. I'm in the Department of Radiology at the University of California, San Francisco. And this is a talk on hardware developments in CT and what they've done for dose reduction. So if you look at the history of CT, there are really two things that have very significantly expanded the application of CT. One is the ability to go faster. So going faster means there is less patient motion, and consequently there are more clinical applications. It does require, in and of itself, going faster, bigger, stronger X-ray tubes that can produce higher X-ray tube currents, and it does put greater challenges on the detectors. So clearly times have shortened, and there had to have been developments in X-ray tubes and in detectors to accommodate this. The other big change is in multi-slice imaging. So this allows for greater use of the X-ray beam, more efficient use of the X-rays being emitted. So it shortens study times and it reduces the demands on the tube. So just very idealized timeline of scan speed or scan time versus year. And you see this very dramatic reduction over time, the initial slope enabling body scanning. So the initial CT was applied to heads. Heads could be held very still. Scan time was in the neighborhood of 5 minutes. And of course, by about 1980, this had been reduced into the few second range, and CT was being applied widely to body imaging, but the scan time has continued to go down and is now in the neighborhood of less than 0.3 of a second on the fastest machines, even though clinically, more often than not, a half-second or 1 second scans are used. Still, this has enabled scanning of many organs that, such as the heart, which obviously are difficult to image if you have long scan times. So if you ask the question, how have CT developments impacted dose? I think you have to answer that in a couple of ways. Overall, dose has gone up. So why is that? Well, it's gone up to the general population because of greater utilization of CT. So certainly the impact on the population has been really very positive. We now are able to get better diagnostic information, and consequently CT is being used to a greater extent. Clearly we want to make sure that our utilization is appropriate. So we saw that from 1980 to 2005, there was this tremendous increase in the number of scans by about a 20-fold factor. But part of that also resulted in a use of thinner slices and more slices per study. So the dose to an individual actually did go up between a scan done in 1980 and one in 2005, because as you use thinner and thinner slices, it's going to require more and more radiation to maintain the same image quality. So in part because of the recognition of the greater utilization and the increase in the radiation dose, there have been very significant reductions in the last 5 to 7 years that can reduce the dose to an individual for a given procedure by at least 40%. So dose levels for a given procedure we know can be decreased by a number of ways. One is by eliminating repeat scans. So it used to be, for example, that pre- and post-contrast scans were more common than they are now. Not saying they aren't done now, but frequently the post scan is the only one taken, eliminating one complete series. There are also greater awareness of dose levels and careful setting of acquisition protocols. This has been a major effort at most institutions to really look at their protocols and make sure they are using appropriate protocols, size-adjusted protocols, so that the dose can be reduced. And lastly, the dose-reducing technology of the scanners themselves. So minimizing dose, we know we have what we call tube current modulation. There have been reconstruction algorithms. We can adjust the KV based on patient size and possibly use bismuth shielding. So I'm going to start with hardware, tube current modulation. It vary the tube current as a function of the X, Y, and Z position. So in other words, as the source rotates around the patient, along the scan length of the patient, the current is adapted for different patient sizes and also for attenuation variations within the scan plane along the patient's anatomy. So you tend to have low frequency changes along the Z-axis, that's the axis of the table, and high frequency current changes with angular position within a given plane. So this is a slide from work done at UCLA, among other places, and you see the yellow line represents the average tube current. The red line shows the current along the Z-axis, the average within a slice, and the actual fluctuations are shown in blue, so very rapid changes as the source rotates around. So it seeks to produce equivalent image quality throughout the entire scan length. That's the purpose of tube current modulation. And protocols set the image quality parameter, the target quality parameter, and it's based on exam type, image quality requirements, and it usually is different for pediatrics than for adults. So Philips and Siemens adjust the tube current based on feedback, but their initial prediction is based on the scout view, whereas GE does a predictive calculation based only on the scout view. Uses only a single view. It does require careful centering of the patient, and it produces a patient model for MA prediction, a relatively complex calculation. So the importance of centering, this is some work done by Jim Koffler showing what can happen and why centering of the patients is important. You see three different patient sizes, or really the same patient, the same patient imaged from three different positions. Remember, you're only using one scout view in the calculation here, and depending on where the patient is in the field of view, you get very different body parts, apparent body part sizes, even though it's the same patient. So what developments have occurred in tube current modulation? Well, less dependency on centering for planning or feedback of the operator. That is, to provide the operator better information on how well they have centered the patient, and wider use of organ-based tube current modulation, which is now offered only by Siemens, and which can save dose to certain superficial organs. But it does need greater flexibility in its implementation. So here is an example of why, if you have a fixed angle where you're reducing the tube in the 120 degrees above the patient, the anterior, and then posterior you're increasing the output of the tube so that the overall current MAS for a given slice is the same. And you see that it works for one patient and not for another. So it does depend on anatomy, and you really need greater flexibility in the selection of those angles than currently is offered. Well, what about other hardware? So better integrating detectors. You know, where can we go in the future to reduce dose? Can we produce better detectors? Well, one way would be to create detectors with better X-ray stopping power. In other words, that waste less of the radiation. However, the current detectors are greater than 95% efficient. So you only have a 5% efficiency to play with. So there's not much room for development, and really unlikely that this will have much impact on dose. There may be some improvements that can be made in lowering the detector noise. This is either electronic noise or in response time of the detectors. It could have some impact on dose, but not as great as one might think. So the bottom line is that detectors really are very good right now, and there may be some opportunities for dose reduction here in the future, but it isn't particularly great. Well, what about photon counting detectors? Now here is a change in the detector technology. So right now the detectors are integrating detectors. They simply look at the amount of energy deposited in the detector in a finite sample interval. However, if you could actually count the photons, there is potential to reduce dose by a factor of 2 or so and maintain the same noise level. Furthermore, if you can simultaneously energy discriminate, you would be able to do material decomposition and correct for some of the artifacts currently seen in CT images. So photon counting detectors would be a true change in the technology that would enable a lower dose. But it's difficult to do. For one, very high count rates are needed, somewhat in the neighborhood of 50 million counts per second per millimeter squared. And some systems have done pretty well, maybe a factor of 5 to 10 below what would be ideal. The initial application is likely to be areas that are less dependent on scan speed, in particular imaging of the breast or some preclinical systems where, again, scan speed may not be as important. And the other challenge with photon counting systems is their very high cost at this point. Certainly, if these were introduced, the cost of them could be expected to come down, but at this point in time, they're strictly research devices and the cost is very high. So how do you do photon counting? Well, you use a different detector. You use a semiconductor, which is a direct X-ray converter. So you can implement this either as a vint-based, meaning strictly a binary system. Yes, I got a X-ray detected or not. Or what would be better, as I indicated, is if you could actually look at the energy of the photons. I detected an X-ray and how much energy was deposited within the detector. This would eliminate light and afterglow issues, although you have to have very fast response from these detectors, extremely fast response, if you're going to hope to make a competitive machine. So there are some semiconductors that are now in use in nuclear medicine cameras, but nuclear medicine has much, much lower photon count rates. They use a special electronics called ASIC electronics, application-specific integrated circuit, which enables some of the fast counting rates. And they use this as part of the ADC and for energy binning, but there is a large amount of effort by the part of all of the vendors to at least explore photon counting technology. The detector that is, there are a couple of detectors that have been proposed. One is silicon. Its drawback is it only has an atomic number of 14, which means that its cross-section for X-rays is quite low, but it is a well-established detector. That is, the technology for obtaining pure crystals is well known, and it's relatively inexpensive, but as I indicated, it has this poor X-ray stopping power, and it also tends to scatter because of the Compton scattering tends to be a predominant interaction as opposed to photoelectric. So there may be some possible improvement in conventional detectors, better implementation of tube current modulation, and at some point in the future, perhaps even 5 years or so out, we might expect some tube current or photon counting machines that further enable dose reduction. But it may be less than 5 years for some very specific types of CT scanners, including breast machines. But overall, in the near term, software developments are likely to have a much greater impact than any development in the hardware. Thank you.